for primary care practice. This is Sarah Fincham, your faculty, and this week we're going to be focusing on evaluating and treating select problems of the head, eyes, ears, nose, and throat, and mouth. Some of our all of our subtopics this week include acute vision changes, corneal abrasion, ocular foreign body, hearing changes. I don't really cover, hearing changes from all, comprehensively, but I do focus on hearing changes related to cerumen impaction and foreign bodies. I don't cover sensory neural hearing loss or go into other details of hearing loss from infection of the middle ear, things like that. But so kind of a focus on those two things. Epistaxis or nosebleeds, nasal foreign body removal, tooth avulsion or a tooth coming out of the socket from dental trauma. And there are some procedures this week that you will be assigned to. All right, let's dive into from dental trauma. And there are some procedures this week that you will be assigned to. All right, let's dive into some acute vision changes. So the risk for vision changes increases as we age. Impaired vision should always be referred to an optometrist or ophthalmologist. An optometrist has a doctoral degree. Impaired vision should always be referred to an optometrist or ophthalmologist. An optometrist has a doctoral degree. They are an eye doctor, but an ophthalmologist is actually a medical doctor, so a physician who specializes in the eye. So, many times they will work together in the same office. The office that I go to has both, and but an ophthalmologist is going to be doing the eye surgeries and probably like eye injections to treat wet macular degeneration. So there's going to be some differences in their scope of practice, but for all intents and purposes, either one can evaluate.
Police reported ahead.
The optometrist can then refer on to the ophthalmologist. So anyway, I, for example, refer people to a local eye clinic, and I know that they have both, and the eye clinic is just going to schedule them with the appropriate person, and they will take it from there. So I hope that makes sense. So the differential diagnosis when someone has acute vision changes, it could be a variety of causes. It could be refractive error, acute injury to the eye. It could be cataracts, but that's not an acute change that will happen over time. It could be glaucoma, macular degeneration. The wet type is acute. The dry type is changes over time, more slowly. It could be diabetic retinopathy, retinal detachment, which is a medical emergency. It can be sometimes associated with like flashes of light that the patient will see. It could be infection, but that's not the most common unless you've had a intraglobe like puncture wound. So migraine with aura can cause bright, shiny lights that appear to be in the visual field, but they're actually sort of a brain source of that light. Traumatic brain injury or multiple sclerosis. Migraine with aura, that visual change will typically only last 20 to 30 minutes, and then it will completely resolve on its own, and then it will usually be followed by a headache. So that's kind of usually the pattern that follows. But migraine can present as stroke type symptoms, or like similar to retinal. It's not like the same as retinal detachment symptoms, but to somebody who doesn't know any better and they're telling you that they're seeing bright lights, that's going to sound to us as a clinician very similar. So just be aware that migraine with aura can be a kind of a tricky thing. Patients can get numbness, tingling, bright lights in their visual field, stuff like that. So it can be kind of scary if you see it for the first time and somebody's having new complaints of that. So, but the timing is really important of that. The fact that it resolves and then is associated with a headache, that's the kind of the key there. And of course, you have to use your judgment. And if it's a company, that's where your review of systems and your physical exam can be really important, because if there's any suspicion that it could be something else, stroke, TIA, retinal detachment, we have to evaluate further for those red flag diagnoses. When you're taking your history, you're going to ask about the timing of the vision changes. Were they sudden? Were they gradual? Describe it to me. The location, is it one eye? Is it both eyes? Migraine with aura will be present either eye. So if they cover one eye or they close one eye and leave the other open, they'll see it. If they close both eyes, they'll still see it usually, because it's not coming from the retina itself. It's coming from that area of the brain, the visual area. History of so have them describe the quality, like describe it for me. Describe what you're seeing or experiencing. Any history of head or eye trauma associated with this visual change? Have you had any recent surgeries that might be putting pressure or inflammation around cranial nerves? Have you had any chemical injuries or occupational injuries to the eye? Splashes, chemical splashes. This is where your past medical history becomes really important. What other conditions, health conditions, are on their problem list in the medical record? Important, I think, really helpful to review your anatomy of the eye, just to kind of visualize where problems might be occurring, the source, and etc. But physical exam tests in infants, if an infant is well, this would usually be done in a well visit, because we don't really know. Infants can't communicate to us if they're having visual changes. But during a well visit, it's really important. At 2 months, infants should start being able to track things. So they're following with their eyes objects that are interesting to them, and they're closer up to them. If they're not doing that, that might be a sign of some kind of vision problem or developmental delay. You can test the direct and consensual pupillary response for cranial nerve 3. Exam of the eyelids, pupils, orbits. You can check for nystagmus. And direct and consensual pupillary response I was taught as cranial nerve 2 and 3. So I think that's a typo there. But I've honestly read different things in different sources. But to me, the optic nerve is receiving the light that's flashing, and then it's more than one cranial nerve in my view. So sorry for any confusion with that. But so cranial nerve 2 and 3 is what I was taught. Because there's the response of the iris, and that's cranial nerve 3, but the retina, the optic nerve, is detecting that light being shined into the eye. Exam of the eyelids, pupils, orbits. You're just looking for anything that looks abnormal: redness, inflammation. Is there symmetry? Check for nystagmus. Nystagmus in the first year of life should be an ophthalmology referral. Visual field. So can they see in all different, all 4 quadrants of the eye, able to see corneal light. You're learning all this in your nursing 562 course, but corneal light reflex. So when you shine that light, does it hit the same spot on both eyes, or do they? Because if not, they may have strabismus, so they may have weakness of the muscles of one eye that's causing that eye to deviate, and therefore that light will not shine on the same. It will not look the same or symmetrical on both sides. The cover and uncover test can further evaluate for strabismus. So you sort of do the corneal light reflex first, and if that's abnormal, then you can do your cover and uncover test to evaluate further. Checking the extraocular movement. So that's cranial number 3, 4, and 6. And you can do the ophthalmoscopic fundoscopic exam. This is much easier to do when the eyes are dilated. It's very challenging to do when the eyes are not dilated. So and then in your infant wellness exams, it's really important to check for that red reflex. If that red reflex, and if the retina isn't looking like an orangish reddish, yellowish orangish reddish color, if it's looking white or opaque or gray, that can be a sign that there is something wrong and potentially a growth on the retina or other problems. We have our visual acuity test, which is testing cranial nerve 2, as well as some other brain function. The Amsler grid tests central vision. Tonometry tests intraocular pressure, so it can detect glaucoma. Fluorescein dye can detect corneal abrasion ulceration. I find it really hard to see corneal abrasions with the naked eye. You can use fluorescein dye, but I will usually refer patients to ophthalmology or optometry if they have any kind of eye pain and it's not an obvious. If it's not, if I don't see anything on the physical exam, but they're having pain and I'm uncertain if they have foreign body or, sometimes those foreign bodies can be so small that they can't be seen by the naked eye, yet they cause a lot of pain and discomfort for the patient. This is what a patient might describe their vision to be with cataracts. It might look sort of hazy like this. With glaucoma, they can lose peripheral vision. With macular degeneration, they lose central vision. So this is what their vision might look like or what they might describe. And a really helpful test for patients that's cheap and easy they can test for wet macular degeneration is the Amsler grid. And the way you do this is you have this little piece of paper, the patient holds it about a foot away from their eyes, and they cover one eye, they stare at the dot in the center, and they look, and by staring at the dot in the center, they ask themselves, do any of these lines look squiggly, blurry, or do I have any cloudy or hazy or dark spots? If they do, they need to have further evaluation by an ophthalmologist or preferably an ophthalmologist, but or optometrist. Acute or age-related macular degeneration. I think I'm going to skip through this and let you guys look through this. There's two types. There's dry type and wet type. Dry is more common, but wet is much more serious and associated with acute vision loss. There are some treatments for this now. There weren't treatments for this, 20 years ago. There weren't good treatments or really any treatments, but now their vision can be preserved, or they may even be able to get back some of their vision. And that's such a big deal for people. So it's amazing and awesome. So basically, wet macular degeneration is when you get these abnormal growth of vessels on the sort of underneath the layers of the retina. They start to become leaky, they leak fluid, they leak blood, and they start to cause scar tissue. So you lose your central vision because it's the macula area. Patients may not know, they may not notice it right away. That's why that Amsler grid can be really important if they're noticing any visual changes. They need an exam. They need to use, we need to use the Amsler grid. They can keep that at home if they know they're at risk for macular degeneration because they have family members who have it, and they can use that, and we can teach them to do that, and then call if they have anything abnormal, or we can use it in the clinic setting when they present. But there are some tests that we can use that the ophthalmologist and ophthalmologist actually will use to diagnose wet macular degeneration. And then here's a really nice 4-minute video that kind of sums up wet macular degeneration. And this is what, if a patient with wet type macular degeneration is looking at a clock face, they might be able to see, they can still see that their peripheral vision is preserved, but their central vision is lost or has spots that aren't spots that are dark, for example. Detached retina, you might start to see this kind of a pattern of vision, as well as you might see some flashes of light. Retinal detachment is a medical emergency. These patients need to be referred to the emergency room, and then the ophthalmologist on call will be called in. Patients will lose their vision because the blood flow to the retina will cause the cells will start to die. So this is a medical emergency, needs treatment right away. Corneal abrasion let's talk about that, often occurs from foreign body, and we have this sort of important, I think really helpful to review your problem list in the medical record. Important, I think really helpful to review your anatomy of the eye, just to kind of visualize where problems might be occurring, the source, and etc. But physical exam tests, in infants, if an infant is, this would usually be done in a well visit because we don't really know. Infants can't communicate to us if they're having visual changes. But during a well visit, it's really important. At 2 months, infants should start being able to track things. So they're following with their eyes objects that are interesting to them and that are closer up to them. If they're not doing that, that might be a sign of some kind of vision problem or developmental delay. You can test the direct and consensual pupillary response for cranial nerve 3. Exam of the eyelids, pupils, orbits. You can check for nystagmus. And direct and consensual pupillary response I was taught as cranial nerve 2 and 3. So I think that's a typo there. But I've honestly read different things in different sources. But to me, the optic nerve is receiving the light that's flashing, and then it's more than one cranial nerve in my view. So sorry for any confusion with that. But so cranial nerve 2 and 3 is what I was taught. Because there's the response of the iris, and that's cranial nerve 3, but the retina, the optic nerve, is detecting that light being shined into the eye. Exam of the eyelids, pupils, orbits. You're just looking for anything that looks abnormal. Redness, inflammation. Is there symmetry? Check for nystagmus. Nystagmus in the first year of life should be an ophthalmology referral. Visual field. So can they see in all different, all 4 quadrants of the eye, able to see corneal light. You're learning all this in your nursing 562 course, but corneal light reflex. So when you shine that light, does it hit the same spot on both eyes, or do they? Because if not, they may have strabismus. So they may have weakness of the muscles of one eye that's causing that eye to deviate, and therefore that light will not shine on the same. It will not look the same or symmetrical on both sides. The cover and uncover test can further evaluate for strabismus. So you sort of do the corneal light reflex first, and if that's abnormal, then you can do your cover and uncover test to evaluate further. Checking the extraocular movement. So that's cranial number 3, 4, and 6. And you can do the ophthalmoscopic fundoscopic exam. This is much easier to do when the eyes are dilated. It's very challenging to do when the eyes are not dilated. So and then in your infant wellness exams, it's really important to check for that red reflex. If that red reflex, if the retina isn't looking like an orangish reddish, yellowish orangish reddish color, if it's looking white or opaque or gray, that can be a sign that there is something wrong and potentially a growth on the retina or other problems. We have our visual acuity test, which is testing cranial nerve 2, as well as some other brain function. The Amsler grid tests central vision. Tonometry tests intraocular pressure, so it can detect glaucoma. Fluorescein dye can detect corneal abrasion ulceration. I find it really hard to see corneal abrasions with the naked eye. You can use fluorescein dye, but I will usually refer patients to ophthalmology or optometry if they have any kind of eye pain and it's not an obvious, if it's not, if I don't see anything on the physical exam, but they're having pain and I'm uncertain if they have foreign body or, sometimes those foreign bodies can be so small that they can't be seen by the naked eye, yet they cause a lot of pain and discomfort for the patient. This is what a patient might describe their vision to be with cataracts. It might start look sort of hazy like this. With glaucoma, they can lose peripheral vision. With macular degeneration, they lose central vision. So this is what their vision might look like or what they might describe. And a really helpful test for patients that's cheap and easy it can test for wet macular degeneration is the Amsler grid. And the way you do this is you have this little piece of paper, patient holds it about a foot away from their eyes, and they cover one eye, they stare at the dot in the center, and they look, and by staring at the dot in the center, they ask themselves, do any of these lines look squiggly, blurry, or do I have any cloudy or hazy or dark spots? If they do, they need to have further evaluation by an ophthalmologist or preferably an ophthalmologist, but or optometrist. Acute or age-related macular degeneration. I think I'm going to skip through this and let you guys look through this. There's two types. There's dry. They need to have further evaluation by an ophthalmologist or preferably an ophthalmologist, but or optometrist. Acute or age-related macular degeneration. I think I'm going to skip through this and let you guys look through this. There's two types. There's dry type and wet type. Dry is more common, but wet is much more serious and associated with acute vision loss. There are some treatments for this now. There weren't treatments for this, 20 years ago. There weren't good treatments or really any treatments. But now their vision can be preserved, or they may even be able to get back some of their vision, and that's such a big deal for people. So it's amazing and awesome. So basically, wet macular degeneration is when you get these abnormal growth of vessels on the sort of underneath the layers of the retina. They start to become leaky. They leak fluid. They leak blood, and they start to cause scar tissue. So you lose your central vision because it's the macula area. Patients may not know, they may not notice it right away. That's why that Amsler grid can be really important. If they're noticing any visual changes, they need an exam. They need to use, the Amsler grid. They can keep that at home if they know they're at risk for macular degeneration, because they have family members who have it, and they can use that, and we can teach them to do that, and then call if they have anything abnormal, or we can use it in the clinic setting when they present. But there are some tests that we can use that the ophthalmologist and ophthalmologists actually will use to diagnose wet macular degeneration. And then here's a really nice 4-minute video that kind of sums up wet macular degeneration. And this is what, if a patient with wet type macular degeneration is looking at a clock face, they might be able to see, they can still see that their peripheral vision is preserved, but their central vision is lost or has spots that aren't spots that are dark, for example. Detached retina, you might start to see this kind of a pattern of vision, as well as you might see some flashes of light. Retinal detachment is a medical emergency. These patients need to be referred to the emergency room, and then the ophthalmologist on call will be called in. Patients will lose their vision if this, because the blood flow to the retina will cause the cells will start to die. So this is a medical emergency, needs treatment right away. Corneal abrasion let's talk about that, often occurs from foreign body, and we have to sort of make an assessment. Is this a superficial injury, or is this a penetrating injury? We can do that sometimes from the history. If we again, I'm going to refer all of these patients to optometry, ophthalmology, but if there's any kind of penetrating injury into the globe, that's a serious risk for losing eyesight, for infection. That's an emergency, or it's urgent and it needs to be referred to our eye colleagues and specialists. So I'm trying to think here. So, the clinical presentation might include a variety of things: foreign body sensation, blurry vision, tears, pain, photophobia, conjunctival injection. So the bulbar conjunctiva might be inflamed, red, or the bulbar and the palpebral conjunctiva might both be reddened, but certainly the bulbar will be likely to be reddened. Swelling of the conjunctiva. Foreign bodies can be really hard to see with the naked eye. That's been my experience. Sometimes a metallic foreign body will leave a little rust ring, but it takes a little bit for that to develop. Again, I'm going to refer these to ophthalmology. But the goals of treatment are to remove the foreign body, control the discomfort, remove the rust ring. They actually have to sometimes remove part of the cornea, and then decrease the risk of secondary infection, promote corneal reepithelialization, so healing of that area. And then a huge goal is to prevent re-injury. So recommending eye protection is so important. That's some awesome anticipatory guidance that we can talk to our patients. So if we know our patients are at risk for an occupational injury to the eye, let's take that opportunity to give them some anticipatory guidance and recommend eye protection. Very common to get ocular foreign body. And then the foreign body, if the patient rubs their eye, will cause a corneal abrasion. And these can be very painful, very, very uncomfortable. If a patient gets a chemical splash to the eye, they really need to flush that eye out with either normal saline or lactated ringers, ideally. And if not, then use tap water. You need to flush these immediately before the exam. You want to prevent as much injury to the eye as you can. So flush first, exam later for any kind of splash injury. Let's move on to cerumen impaction and foreign body of the ear. So, cerumen is otherwise known as earwax is the layman's term. It moisturizes and protects the external auditory canal. Patients with cerumen impaction or foreign body will often present talking about their ear feeling quote unquote full or clogged, or they'll describe sometimes hearing loss. And it'll usually be like, I could hear fine 2 weeks ago, but today I feel like I can't hear out of this ear. That's kind of how some of the patients I've seen have presented. So it's like that cerumen has been building up slowly, but it's finally gotten to the point where it's impacting their hearing. So it seems to reach a breaking point, where it starts to at least that they start to notice the hearing loss. So even though the cerumen has been building up over time, they might have dizziness. That's not really a presentation that I've seen, but they might have ear pain or discomfort. Again, that hasn't been typical in the patients that I've seen, but it's possible. They may have itchiness or irritation in the ear. If there's infection, so with foreign body of the ear, they're more likely to have dizziness or pain. With cerumen impaction, they typically do not have pain. And with cerumen impaction, they're not going to have infection or drainage. But with foreign body of the ear, they absolutely can develop infection and then have drainage as a result of that infection. So tinnitus or vertigo or reflex cough or hiccups, these are all different presentations that patients might have. So, and some of these, of course, are these are all really symptoms. None of these are really signs. So, you're going to perform an ear exam using your otoscope. And if you just see cerumen and you can't see anything else, that's most likely the source of their hearing loss. You have to though ask them first, make sure it's safe to do an irrigation of the ear canal. So do they have any history of radiation to that area that might have damaged those structures, and then you flush it and you're introducing fluid into the middle ear, the inner ear, things like that, causing further damage. Do they have any recent or past perforation of the tympanic membrane? Do they think that, is there a foreign body in there, and is it a battery? Is it anything that could cause necrosis or injury or a sharp foreign body? Is there a history of prior surgery to that ear, to the tympanic membrane? If so, it might be weak and it might be susceptible to rupturing or perforating when you do the flush. If the patient has onset of pain or severe dizziness while you're doing the ear canal flush, some minor dizziness might be normal, especially if the water or fluid that you're using is cold. So warming that to lukewarm, testing it, make sure it's not too hot, like on your inner wrist, for example, but might help with prevent some of that discomfort or dizziness. And then if they have history of surgery to the middle ear, that's going to be a contraindication to ear canal irrigation. You can use a curette, so just kind of this little, how would you describe it? It's almost like a little tiny cup-shaped plastic or metal tool that you just use to sort of chip away at, kind of little by little, removing that earwax. It's really easy to go too deep and cause pain. The tympanic membrane looks far away when you're using your otoscope, but then you'll find quickly when you use your curette that the patient will feel that and it will cause discomfort. So I always try and tell them, like, don't jerk, because I don't want to hurt you, but this is a really sensitive area, and if this is feeling uncomfortable, just tell me stop, or use one word to tell me that it hurts, and I'll be more careful. But yeah, so you're just trying to stay really shallow and just get a little bit of earwax at a time. You don't want to get too aggressive with it or it'll cause pain. But you can also use warm water irrigation. I've never used suction, but I use the others. Patients with any kind of foreign body who have a history of any kind of condition that can cause immunosuppression, so older age, diabetes, anything like that could cause immunosuppression, might be susceptible to get an external ear infection, and so you might want to give some prophylactic topical antibiotics for those patients. Refer patients to audiology or otolaryngology, ENT, when they have when you're not. So foreign body can be something that you could remove in the clinic setting unless it meets certain criteria, and then it needs to be referred to ENT. So you wouldn't refer. I need to kind of work on this slide. So foreign body, you would be referring to ENT. Hearing loss that seems like sensory neural, you would be referring to potentially to audiology, but most of the time these two work in the same office. That's been my experience. So again, it's a situation where you refer the patient to that specialty clinic, and then they decide which provider, based on the patient's complaint and presentation, which provider they're going to see first, and maybe they'll see both. A lot of times you'll have hearing tests by the audiologist in preparation before you see the ENT. But if you're not able to visualize that foreign body, it's got to be referred to ENT. If it's a hard or round object that is kind of lying against the tympanic membrane, it's got to be referred to ENT. You don't want to risk perforating the tympanic membrane. Disc batteries, sharp foreign bodies are going to potentially rupture or perforate or cause more damage when you try and withdraw them. So let ENT do that. If you have a really uncooperative patient, a really young patient who is not going to hold still for you, refer to ENT. So any object that would basically be hard to remove would be potentially damaging to tissues as you withdraw it. Hearing problems, to refer to audiology/ENT. If you suspect sensory neural hearing loss, and you can use your Weber and René test to try and understand, is this conductive hearing loss or sensory neural hearing loss. Those are really good tools that we have in the clinic that we can use to decide whether what the source of the hearing loss is. Cholesteatoma must be referred to ENT. That can be, the patient can lose their hearing with that because it's a benign growth that just starts to take over and starts to damage the inner ear eventually if it goes too far. And they'll lose, if it's conductive hearing loss at first, but eventually it could become sensory neural if that growth continues to grow and causes necrosis and lack of blood flow and necrosis to the inner ear structures or the middle ear, but both. Chronic persistent ear infection should be referred to ENT. So epistaxis is pretty common. There's going to be a lot of patients that you're going to see possibly just out in the community most of the time, not necessarily presenting to clinic, that have a nosebleed. Most of the time, the bleeding source is this anterior septal area, this Kesselbach's plexus area, it's so called. In those cases, the blood will come out anteriorly. Sometimes you can get a bleed of the vessels back in the back, and that may come back down the throat. These are going to be, really next to impossible to treat in the clinic setting. These are treatable. So these are probably be potentially referred to the ER, and then ENT will be called. So if the bleeding is not stopping, then that's, after implementing several measures, then refer. Of course, some people are going to be susceptible to nosebleeds. People that are on certain medications like blood thinners or anticoagulants or who have chronic conditions. Usually the patient will present, I'm sure most of us have seen a nosebleed in our time, but the bleeding will come from the nose. Typically, it might run down the back of the throat, but usually it'll come from the nose. They may have some dizziness. They may kind of get anxious. That's more a response to the stress of the nosebleed than to the blood loss itself, typically. But if they're becoming pale, and their pulse rate is high, and you suspect that's because they've had a lot of blood loss, most likely that's a posterior nosebleed that is not stopping. So we can use manual pressure, a nose clip, topical vasoconstriction. So like Afrin is a vasoconstrictor, silver nitrate. We can use nasal packing or tampon. We can use nasal packing with a vasoconstrictor added. So you could add Afrin to that, like if the patient was at home. Most of the time, you just need to try and put pressure on this anterior septal area. So if you just feel your nose and just feel the bony part, that area right below the bony part needs to have pressure applied. And I usually just tell patients, keep your head forward slightly. Don't tilt your head back, so we don't want that blood going back down the throat. And it doesn't help stop the bleeding to tilt your head back. So keep it forward, apply pressure, firm pressure, not painful, but firm pressure to that area, and a minimum of 5 minutes. Up to 10 minutes. That's a really long time for patients, but that's what you need to do. Otherwise, it might likely just start bleeding again. So I'll just usually tell them, grab a tissue, apply pressure to that area just under the bony part, and firm pressure, head tilted slightly forward, keep it there for like a minimum of 5 minutes, and then let's reassess. So nasal foreign body removal, this is mostly going to be children. Sometimes patients with developmental disabilities will be more likely to present with a nasal foreign body or child. And so typically it'll be like food, small objects that the patient will put up there, or they might like sniff it up there just to see what might happen. I know that sounds like an odd thing to do, but people will do. Sometimes kids will do that, and then they start to panic because it actually went up there farther than they thought, and they can't get it out. So the patient will have pain. Usually they'll be kind of panicking, like they'll appear very anxious. Nasal discharge or drainage is going to be like a later stage, like if there's an infection and that foreign body's been there for a while. But if it's just happening acutely, they're going to have probably anxiety, and then they're going to tell you that there's something in their nose, and that's going to be their main presentation. You will hopefully be able to see that foreign body on exam, and you can use bayonet forceps, a curette, the earwax removal tool that we spoke of, or the parent's kiss method to try and withdraw that. If you close the other nair and the parent, healthcare providers, we don't do this to patients because we don't want to put our mouth on a patient's mouth, introduce bacteria, etc. But the parent can kind of, if they're at home and they call, or if you're out in the field setting, they can close the opposite nair just by putting a little bit of pressure on it with their finger, and then they can put their mouth over the young child's mouth, and then they can blow gently, and that might dislodge and kind of push the air might push that foreign body out the nair where it's lodged. Probably they're only going to be able to do that to a young child. None of my kids are going to probably allow me to do that. So little kids will let you do that. Once they get older, hopefully they're going to be able to hold still for you, and you're going to use forceps or something like that. And when they're older, they're not going to likely have a foreign body in their nose. That's usually something a younger child will do. Young school age to toddler and preschool age, typically. Lesions of the oral mucosa, there can be all sorts of lesions that happen in the oral mucosa. The mouth can be kind of a display area for all sorts of conditions that are going on in the body. But it can be scary when you see lesions in the mouth. Sometimes they'll just be benign lesions. Oftentimes they'll be benign lesions. But leukoedema, four-dye spots, physiological pigmentation, mucocysts, these are all common. These are normal variants of oral mucosa that are not worrisome. I've seen a lot of mucocysts. It looks like a little tiny, it's a growth, but actually it's just serous fluid that has kind of built up under the outer layer of the mucous membrane, and it will go away. It may take time. You can sometimes just drain it with a sterile needle and then express and just kind of apply pressure. It may come back though, but it's usually round. It appears cyst-like, and it can appear white or it can appear sort of clear color, but those, and they don't have usually any redness associated. So those are common. These are all normal variants of oral mucosa. So how do we know if it's an abnormal lesion that's worrisome and that we need to refer to somebody for? So if it's red or white colored, let's have it get further evaluated. If it's and it's not a mucocyst and it's not consistent with any of these other things. If it's been present for 3 or more weeks and it's starting to become getting into that chronic stage, consider referral. If it's an ulcerated area that is not healing over a few weeks and it's becoming chronic, that needs to be further evaluated, for cancer or other problems. If it's a lump and it doesn't resolve and it doesn't appear to be an infection, or even if it does appear to be an infection but it persists, that needs to be referred. If a patient ever has anything in the oral cavity that's visible associated with any enlarged lymph nodes, that it doesn't mean that lesion is dangerous or cancerous, but it means it must be evaluated further. That is indicative of potentially an immune response happening. Those lymph nodes are trying to do their job and they are becoming enlarged, and that can be an indication that there's something going on that's more serious in the mouth and throat, and must be evaluated. So send them to somebody who is an expert on that area of the body, or like an ENT who can look in areas that we can't look. So they have tools at their disposal and expertise that's going to allow them to do a more extensive exam than we can do with the naked eye with the tools that we have in the training we have in the clinical setting. But just think about where lymph nodes drain from. So think about the area that the lymph nodes drain, and then you need to refer the patient to a provider who can look at that area. If there's any persistent lymphadenopathy, if there's any persistent lesions of the oral mucosa. Risk factors for squamous cell carcinoma of the oral mucosa, which usually occurs on the very posterior part of the tongue or in the tonsillar area. The HPV likes those tonsillar tissues. The risk factors for that are having an HPV-16 infection. Nobody would know that. We really don't screen for that. But tobacco use. Oh gosh, I forget how to pronounce these. This is a net that people use as a stimulant in certain countries. Not something that I've ever seen any patients use in my practice, but it can apparently cause some inflammation and it causes some kind of changes to the tissue that can put the patient at risk for squamous cell carcinoma. Alcohol use, Southeast Asian descent, male more so than female, can be at risk for squamous cell carcinoma of the oral mucosa. There's something else I wanted to say. So maxillofacial surgeon is a dentist, someone who's gone to dental school and medical school. So that's that. ENT is a physician, so a medical doctor or a doctor of osteopathy that has specialized in the nose, throat, basically nose, nasopharynx, and pharynx. And a dentist has gone to dental school. So lesions of the oral mucosa, more history and information and exam that we should perform. So have they had any dental work or any appliances that could be causing irritation, friction, and be causing that lesion? Is it just the sheer rubbing that's causing that problem? What's their medical history? What medications are they on? You're trying to understand if they have any autoimmune conditions that could cause lesions in the mouth. If they could be getting mucositis from HSV infection, they immunosuppressed, so they're getting like a herpes infection in the mouth because of that. Current cancer treatment, immunosuppressive meds. It's really common to have herpes simplex 1 in the mouth. I think many people don't know they have it until they perhaps undergo cancer treatment and become immune suppressed, and then they sort of get these lesions that can happen. You can also just get mucositis from the cancer treatment itself, targeting those fast dividing cells of the mucous membranes. Alcohol, misuse can be, you want to ask about that. Tobacco use, what type? Are you packing it? Are you using a loose leaf? What are you using and how long and how much? Do your review of systems and ask, are you a cheek biter? Do you have any other, you can do a full body review of systems and see if that's helpful. The exam should include not only of the mouth, but you want to look at the face and neck for symmetry or asymmetry, look for any swelling, look for any masses, look at the lips, look at the skin on the face, palpate the lymph nodes. This is really important for the reasons we just talked about. Evaluate the cranial nerves. If there's something going on in the face, evaluating cranial nerves can help give you clues to what it might be. In our case this week, kind of spoke to this. But if you have a lesion, a tumor, a growth, the face is such a small area that if it gets big enough, it can start to put pressure on other structures. So other, cranial nerves, sinuses. So doing a review of systems in your extra oral exam can give you a lot of clues to what might be the cause of this oral lesion or this vague complaint that the patient's presenting with. Okay, so tooth avulsion or dental trauma. This is most likely going to happen in the field, like meaning you're out in the community doing something, and maybe at a sporting event, or patients are going to call your office with this type of complaint. They usually won't be coming in as a scheduled visit for this. It's an acute, like emergent thing that happens. So if they lose a tooth, and it's a primary tooth, it's a permanent tooth, not a baby tooth, or primary tooth, you want to try and save that tooth. It should be replanted because that is going to give you the best chance of those nerves not dying. So this is what you do. You pick up the tooth, or you give these instructions to the guardian, the parent, whoever's there. You pick up the tooth by the crown, the white part, not the nerve ending part. Try not to touch the root or the nerve endings. If it's dirty, you rinse it with something. So you hopefully have, like the patient can rinse it with their own saliva, or if you're in an emergency room setting, you can rinse it with saline or milk. If they're at home, they can rinse it with milk. Something that is going to be less likely to sort of drain the nutrients from those tissues. Water is a last resort. You can use that if you don't have any of those others. Or if the child's like really young and you don't want them, you don't want to put the tooth necessarily and have them rinse it in the saliva if they're at risk for swallowing it. So this can get tough. That's why if it's a primary tooth, you're most likely not going to try and save it. It was going to get lost anyway when they get older. So this is permanent tooth instructions. So you rinse it and then you try to implant it right back into the socket where it came out. That's more just to keep the tooth viable. It's less, the dentist is going to, or the maxillofacial surgeon or dentist, usually dentist, is going to address that issue. You're just almost putting a Band-Aid on the situation just to get them to that specialty provider, and trying to keep those tissues and cells of the tooth alive so that they can actually replant the tooth. So anyway, then you're going to send them on to the emergency department or the dentist. If it's like a weekday in the middle of the day, have them call their dental office, see if they can get them in right away. If it's a weekend, the dental office is most likely not going to be open, then they need to go to the emergency room and they will call the dentist on call or the dental provider on call. You don't want that tooth to dry out. So if the patient's not capable, or if you're not capable for whatever reason of replanting the tooth, then you're going to try and keep it alive by keeping it moist. And, you're going to transport it in a plastic bag, for example, or a cup or something that has either milk, saline, saliva, or water if you don't have anything else. Okay. So yeah, bring the tooth with you. They're going to try to replant. They're going to try and save that tooth essentially. And give patients anticipatory guidance. There's certain sports that are really at risk for tooth avulsion. Baseball surprisingly is one of them because the way the ball bounces unexpectedly and hits people in the teeth. In other sports like football, for example, you think would be a high risk, but they wear a mouth guard, they wear a helmet that protects the face for the most part. So surprisingly, I think often baseball, it's possible in any sport, but particularly in baseball, try to give that anticipatory guidance. I'm trying to think of other sports. I'm sure you guys can think of some others that would be a high risk. Basketball is going to be, of course, more of an elbow, or they hit the floor. That could cause it. But I don't know hardly any players that wear mouth guards. Yeah, that's not true. Professional players do. So basketball, give that guidance. My experience is sometimes people are open to it. But if you can get patients to be mindful of the risk of losing a tooth, like sometimes you can't replant these teeth and you lose your tooth forever, you might be able to convince them to protect their teeth with a mouth guard during their sport. Here's just a quick look at the anatomy of the tooth. Here's the root down here. Here's the top, the enamel. We'll talk more in 513 primary care 1 about the anatomy of the tooth and how to help our patients and how that affects cavities or dental caries and things like that. But sometimes I think it's fun to see the anatomy and just have it refreshed in your mind. Here's the references. And so this concludes our week 6 talk. As always, please post any questions you have to the discussion board Q&A. Please be sure to be checking the comments and the feedback that I'm giving on your discussion board assignments. There is a way, I believe, to turn on notifications if you want to get a message whenever I grade or give feedback. Otherwise, you're going to have to go in and check it. And have a great week. Thank you.